Good evening. In the past 10 or 20 years, gender based medicine has become more of a prevalent issue in today's society. And I say gender based medicine and not sex based medicine. So let's just clarify that. This is being directed towards ER staff. They're currently probably having the most difficult time with this, being that their patients are typically not known to them unless they're what we call frequent flyers. But the difference between gender based medicine and sex based medicine is when you have sex based medicine, you're identifying sex as what the patient was or is genetically or chromosomally designated as male or female based on their genitalia. Now, gender is a little bit different. Gender is typically what somebody identifies. A lot of people who are sex and genetically male will identify as male, but now in the past 10 to 20 years, that is not the issue. Gender has become more fluid. You have people identifying as boys identifying as girls, girls identifying as boys. You have them identifying or currently transitioning from one sex to another. Then you have non-binary. Then you have people who are identify as both or neither. It all gets very confusing. I think at the moment there's 26 genders that are currently identifiable at the moment. So here's where the issue is. As I said, sex, as defined, is a chromosomal or genetic designation of male and female. Now, gender being what they identify as, other than what their sex may, if it's something different than what their sex may be. So they could identify as male, identify as female. It's fluid. Now, apparently, there have been studies that said that this fluidity is not stagnant. They could identify as one or the other on any given day, and apparently that's not an issue. People are saying, oh, well, that's okay because it just all depends on what they feel on the inside. Well, again, it's not actually what they feel on the inside, it's what they feel upstairs. So, now here's some differences, some important biological and behavior differences that we see in the ER. So let's first go with the genetic the male. In the male behavior, when it comes to pain or discomfort, it typically goes one of two ways. One, they will recognize the pain and ask for help and identify, yes, this has been going on, be very truthful with their issues in order to be diagnosed and treated. Or two, just completely deny it to the bitter end and they were almost dragged to the ER. Now, that being said, then it could typically either be a lot worse, or these are patients who don't typically go to physicians for whatever reason in their normal lives. Now, women, it's typically this. It could be one of the two ways as well, but there's also a third. Women could recognize that there is something wrong and that something does need to be done, but it's downplayed. And when it's downplayed, it could be a lot worse than what it is. For instance, we have patients that come in to the emergency room having a heart attack, and while looking at them, they look uncomfortable. Their EKG says they're absolutely having a miserable time. Yeah, it's just a little twinge. Now and then we'll take an angio as a STEMI patient comes through, and I have a total occlusion. It's blocking 2/3 or 1/3 of their heart. Obviously not good. They've got to be in immense pain, but they're just downplaying it for whatever reason. Now, some of the complexities and challenges this creates is in the ER, staff and physicians have been trained for years to treat the physical. We can only treat what we see and what the patient tells us. So if a patient comes in and they have a broken arm, we treat the broken arm. If they come in with a migraine, we treat the migraine. If a patient comes in and they can say, there's something wrong with me, I'm a girl, but I was born a boy, there's nothing we can treat with that, and it's something that's get referred out. Um, so the ER is the place for the physical to be treated. Now, obviously, if there is physical harm being done by the individual because of whatever reason, say you have a genetic male being born, or no, coming into your ER, and they're absolutely certain, they're claiming that they're no female, and they're supposed to be a female, and they're causing harm to themselves and their genitalia, or no any other part of their body to make that so, then yes, that you need to treat the patient and have them admitted for evaluation and see what can be done. Um, Now, one of the differences that uh, this could have, if you think about it, a patient comes in, you have patient A that comes in, and they come in, person has facial hair and a relatively deeper sounding voice, and they're dressed very masculine, and they have they're short of breath. Maybe their legs are swollen or something along those lines. Something's going on, and you're talking to them, or maybe you can't talk to them. Maybe something's going on where they can't speak, and they have had some sort of gender reassignment surgery. So now, physically, they look like a man undressed. They have genitals of a male. They have the chest. They have a flat chest. They have the physical features of a male, but you can't speak to them. You're trying to figure out what's going on. But what you don't know is that this individual was born a female and is taking um, birth control in order to stop their cycle, or do something, aid in the chemical balance in their body to help with their female cycle. Now, I'm not a physician. I don't know the complexities of transgender hormone therapies, but it's that those medications have been known, and it's even on their label now, can cause DVTs and have clotting issues. Um, and we won't know how to treat them. Now, to educate the ER, there's ways to do it. So it needs to be made clear that the the patients do need to inform staff what they physically are and what they identify as. And it's up to the staff and educators to not necessarily understand, because it's not everybody's job to understand, but to accept what that information is. Um, and to be sensitive to those decisions in order for us to provide life-saving care. And without that information from the patients to the staff, and that understanding from the staff to or that acceptance from the staff to the patients, we can't be successful in our jobs. Now, how we can fix this in medicine in the future, need to understand ways that drugs interact with other drugs you're taking, and how gender fluidity works, and different protocols to change documentation to reflect that information, so we can properly diagnose it, properly and respectfully treat and address our patients. So gender-based medicine is only going to be an evolving um, issue from like 10 to 15 years ago and ongoing. So thank you. Good night.